going to speak with licensed social worker Shannon Wagner, who specializes in treating OCD, ADHD, anxiety, and depression. Shannon offers a warm, evidence-based approach to therapy, helping individuals manage the daily struggles that come with obsessive thoughts, attention difficulties, and emotional overwhelm. If you're ever feeling stuck and need more insight about OCD, this is the video that you definitely don't want to miss. Feel more empowered with more knowledge.
And thank you so much for being here on Two Healing Minds. And I know you're the OCD expert, so perfect topic to talk about today on this video.
Thank you, Tanya, so much for having me. I'm really happy to be here.
Okay, good. And OCD is a term that you hear a lot. I feel like people use it loosely or just casually. So, what is the clinical definition of obsessive compulsive disorder, and how does that differ from people that liking to do things a certain way? It-
Definitely. Such a great question and really true that, especially all over social media, people will say they reference themselves as being OCD, or
Mhm.
if someone likes something to be clean, to be like, are you OCD? Um, but in a clinical sense, OCD is defined as having obsessions, which are, they come in the form of like intrusive thoughts, um, that are like very unwanted, distressful. And the compulsion part of OCD are the behaviors or acts or rituals that someone will engage in almost without really wanting to. There's a very strong urge to do those things to help relieve the stress or anxiety from the obsessive thoughts. Um, and it's extremely impairing for um, a person's life and functioning, and it just really disrupts their daily life. Whereas someone who likes something a certain way or wants things to be clean, everybody has their preferences and their quirks, but those things don't lead to impairment if things aren't that certain way or aren't in their preference. Um, OCD can exist with just the obsessions. It's not as common as obsessions and compulsions together. But also, like, just people liking things a certain way, there's typically not the compulsive aspect. So there is a big difference. And I think more people are kind of calling out other people when they say that something is OCD or that they are so OCD, because it can be pretty insulting to people who truly have the diagnosis.
Yeah, it's commonplace for people to use that for anything, like, oh, I'm cleaning a lot, I must be OCD. So it is used loosely. And my understanding is it's the level of distress. Like real obsessive compulsive disorder is just so distressing that it's almost hard to take on your daily duties because or can you distinguish between the obsession and the compulsion?
Sure. So the obsession will be a thought that is intrusive. So it kind of comes out of nowhere, doesn't feel like your own thought. Um, and they're typically, well, they're always in direct opposition of a person's true morals, values, what that person cares about. Um, so the obsessions are the thoughts, and it'll linger there, hence the word obsession, the intrusive thought. And then the compulsion will be something that a person will do in direct response to those thoughts to relieve the distress of the thoughts. Even if it doesn't seem rational, it doesn't make sense, there is just a very strong urge or drive to do whatever that action would be to relieve
Mhm.
that distress. But you're exactly right that true OCD, it's very hard to function um, just day to day.
And
Absolutely.
that leads to my next question. So at least we have a definition, a straight definition of what OCD is. How does OCD develop? Where are its roots? Are there biological factors that contribute to it? Is there a certain time that people develop it? Is it during childhood, adolescence, or you can develop it in late adulthood?
Yeah, so OCD and most mental illnesses, most mental health disorders will typically start by mid to late adolescence. So that's like the
Mhm,
majority of when symptoms would first appear. It is common for OCD to show up for the first time later in life, but
mhm,
really like after 30 or 35 years old, it's not that common. Um, and it's always a combination of nature and nurture of things that
mhm,
kind of predispose us to developing a disorder. But for OCD, there is a genetic component. So, if somebody in your family has OCD or a similar disorder, you're more likely to experience the same thing. Um, Also, just if your temperament, like if you just tend to be a more anxious person or um, have difficulty, with just if you tend to be more prone to anxiety as it is, um, then you're more at risk for that. And there's also the risk associated with trauma. So any trauma during childhood that greatly increases the risk that someone would develop OCD. But typically by mid to late adolescence, that's where most of the time symptoms have started.
mid to late. So it's rare if you're like above 35 and all of a sudden, that's very rare that you develop an OCD.
Yeah, it is pretty rare. Like there can be, if there was like a really big traumatic event or life stressor that would typically trigger it at that point. But yeah, just the way that OCD will begin, like its onset, the natural way, I guess, would be by mid to late adolescence typically.
Mid to late. And so, yeah, a big thing about on this channel is I speak a lot about depression. So I always have to throw in a question about depression. So, can OCD and depression coexist? And in your experience, can a worsening episode of depression, like if your depression is getting worse, can your OCD symptoms get worse? So it's somebody that's already has OCD and they're experiencing depression. So can that get worse?
Yeah, that's a great question. Yeah, absolutely. Any sort of like comorbid mental health diagnosis that's going on, if one tends to get worse, then it's pretty likely that the other one will get worse as well. Depression is really common with OCD. Um, and I think that makes a lot of sense. I mean, if someone has OCD and it's making it hard for them to leave the house, or they're struggling to go to work or maintain their friendships because of these obsessions or compulsions, that would lead to like a really low quality of life, which can cause depression or worsen existing depression. Anxiety disorders they tend to be the most commonly seen amongst people who have OCD, just generalized anxiety or panic disorder, social anxiety. Um, but yeah, life stressors, big life changes tend to increase OCD symptoms as well. Um, but yes, depression and OCD are very often seen together and really affect each other.
So when you're treating someone, you're kind of addressing both. You have to address the depression and the OCD.
Ideally, yeah, there's always a balancing act if there are multiple diagnoses going on. It's, if one thing is truly causing the other, like if the depression wasn't there before the OCD, um, it also depends on which is more severe or what seems to be the most realistic thing to treat first too. Um, it's a balancing act, yeah, and how to address which one first. But typically it's alongside each other.
Yeah, and that sounds like it would be very exhausting having to deal with that or your obsessive thoughts or the compulsions. That's just kind of like almost just eating you away and
Yeah.
hard to deal with that. So I can imagine that in itself is causing can cause depression too.
Mhm.
And also, so OCD people might associate it with like cleanliness. So like, oh, I have to clean. I'm just super organized. I'm super clean. Or checking behaviors. You know, like the person that, oh, did I check the stove? Is the stove off? And oh, is the door locks? Are the doors locked? I have to keep checking. Oh, did I check it? So how do you know like what type is actually an OCD and what's just like, hey, that's just my personality. I'm just a
Mhm.
very responsible, good person, and I'm just yeah.
Yeah,
How would you distinguish that?
right. If those things are impacting your functioning. So if, you really want to make sure your doors are locked, you know, we all want to be safe and keep our home safe. But if it's making you late to work because of how many times you need to go back and check, or if you're at a friend's house and you can't stop thinking about, did I lock the door? And it's making it hard to be present with your friends. It's really about if it's impacting your ability to live life and function. And checking checking or reassurance OCD and cleanliness OCD, contamination are definitely I think the most common that people will think of if they hear of OCD. Um, but there are many more types. Um, there is a perfectionism symmetry OCD where it's about things feeling just right or things needing to be a certain way. Um, there are also OCD subtypes that are related to sexual orientation. So there will be an obsessive thought, an intrusive thought, where you're kind of questioning, well, the thought is questioning, am I actually like what I identify as? Like, what if secretly um I'm not actually straight when
Mhm.
in reality that's not the case. And then there becomes this cycle of however that person is trying to relieve the distress of that obsession. Harm OCD is another subtype, having obsessive intrusive thoughts about the fear of like hurting someone or themselves. And it's really important as I go through these subtypes to emphasize that these thoughts are not wanted, they are not voluntary, they are very much out of a person's control, and they are not a true reflection of what a person wants or their values. So I say that just in going through that these aren't thoughts that people are like sitting and contemplating and feel that they are true. It's the direct opposite, and that's what creates the distress. Um, Another type of OCD, pedophilic OCD. So there's an obsessive fear that someone will harm a child, that they
Oh,
are
wow.
somehow secretly a predator in that way, which is
Hmm.
devastating.
These
Um,
are these are interesting. I mean, I'm sure a lot of people haven't even heard these types, these that you're sharing.
yeah,
As you said,
there
there's just those common ones. How many do you
mhm.
think there are? I mean, it seems like there's just all types.
There are many.
Many.
And I don't know if there are like more to be discovered. I think most of them do fall under these categories. Um, but absolutely, I think the kind of the ones, the harm OCD, sexual orientation, and pedophilic OCD there's a lot of fear and shame associated with that. So it's not talked about as much. There's such a big misunderstanding of OCD as it is. So those subtypes are really hard to talk about. There's also perinatal postpartum OCD. And that one tends to come up during pregnancy or like shortly postpartum, just fears of hurting or harming the baby. Um,
Hmm,
and this is not like,
interesting. Because the reason I say interesting is how do you distinguish that from postpartum depression? Because sometimes they had those
Mm.
kind of feelings too, or it's,
Yeah, that's a really great point. With postpartum perinatal OCD, there is typically like severe avoidant behaviors in response to the obsession. So, I've had a client who was very worried that she was going to like accidentally um, molest her child while changing them.
mhm.
So she just wouldn't change them. Like she refused to change their diaper for months. Um, Whereas opposed to like maybe the thoughts that come up with postpartum depression, those fears would be there, but there wouldn't be that change in behavior because of it. There wouldn't be like an avoidance or um, a reassurance seeking. So that would be kind of the main difference that I would look at is there some sort of avoidant behavior or um, compulsive behavior happening after those fears?
Okay, oh, interesting. And this gets to my next question because it almost sounds like you kind of answered it. So in your practice, is there a particular type of OCD that you find more challenging to treat than others? Even though you kind of describe some challenging ones right now. And if so, why? Why is it more challenging?
Yeah, I think there's no one that's more challenging in terms of like treatment success. Um, in my experience, what seems to be really debilitating and devastating and maybe like just emotionally challenging, and maybe this is because I'm a mom, I don't know, is perinatal postpartum OCD. I've found in working with clients that there is a huge, like huge fear that in telling someone about these thoughts, such as a professional, that their baby will be taken from them. They will be hospitalized against their will. I mean, we all have seen those few but extremely devastating situations where a mother seriously harms or kills her baby. Um,
Yeah.
so I think that is like a really challenging and difficult thing for a new mom or a mom in general to even say to anybody, let alone a professional, and say them out loud. So for me personally, that is just kind of seems to be the feelings of shame and guilt associated are like really heavy. Um, not to discredit any other subtype of OCD. I think they all are very debilitating in their own way. Um, I just seem I just see a pattern of less help, um, more reluctance to seek help.
Yeah, I see that too. As you said, there's the shame and there's the secrecy and that oddness. Like it's
Yeah.
almost like most of these people, they recognize that there's a bizarreness to whatever their thought processes are or their behavior.
Mhm.
Don't you find that they're aware of that? So it's not like, oh, they're clearly aware, like, hey, this is a problem. This is strange.
Yes.
I don't know.
Yeah, there is pretty much they do have an awareness of like almost like I shouldn't be having these thoughts. Um, but then like where the big distress comes in is like them like questioning why am I having these thoughts? Does this mean that these things are going to happen? Does this mean that I really want these things to happen? What if they do happen? Um, so there's just, I mean, that psychoeducation just really helping to normalize and validate like for people with OCD. That's like a huge relief to a lot of people right away. It's like, oh, like these things are so distressing because they're not what you want. They are so opposite of you, and that's what OCD does. It finds the thing that you care about the most, that you value the most, and it attacks that.
Hmm. And as far as from a therapeutic point of view, what are some common misconceptions about what helps OCD and what actually works in therapy. So I know that there's one that I was, looking up what you do. It's called exposure and response prevention, or ERP. So can you explain how you use that?
Yeah, absolutely. So big misconceptions in treating OCD is that people often want to find like soothing or like coping techniques to use in response to the distress from the obsessive thought. So, like I'm picturing a therapist saying, okay, well, that thought isn't true. So let's just take some deep breaths. We'll breathe through it and just remind yourself that these things aren't going to happen and that it's just OCD. Like that sounds great and that works for a lot of mental health disorders, but for OCD, that's just another compulsion. Um, so the treatment of OCD, it's it's ERP, exposure response prevention, is when you work on sitting with the distress from the obsessive thought like as long as possible. Like really just having the thought come up, for example, did I lock the door? But then like not doing anything about it. So you resist the checking or you resist the cleaning of your hands for the 100th time that hour. ERP is like never designed to eliminate the thoughts because we can't control the thoughts, but we can control how we respond to them. And with ERP, we don't respond to them. We simply, I say simply, it's not easy, but it is just exposing yourself little by little to the thought and how that would come out in the world without performing the soothing behaviors that were typically happening before, such as the checking of the lock.
And is that the main modality do you use? Or it just depends on what type of OCD?
That is generally the main focus of treatment is ERP. Um, but I add in a lot of like mindfulness strategies, not in the way to reduce stress, but in the way to like notice the distress. Um, so really like sitting with how uncomfortable you are with this thought and like really noticing where you feel that in your body. Um, I also will utilize a lot of like family focused or like have really close friends or significant others be a part of treatment, especially if there is like a checking OCD or like a reassurance seeking. It's really important that people in their lives are not kind of contributing to the compulsive behaviors. And they're not doing that from a place of harm. They want their loved one to feel better. So they try to like reassure them, like those things aren't going to happen. No, you're okay. I know you locked it, but that's just another form of a compulsion. So it's important to involve the people that are in their inner circle the most as well.
And is OCD something once you have it, you basically have it for life, but it can kind of go up and down throughout life? Like at sometimes it can be severe, and then all of a sudden you feel like, I don't know if you use the word remission, like, hey, I'm not doing it as often. But if then somebody is faced with a traumatic event, something stressful, all of a sudden it presents itself.
Yeah, that tends to be what OCD looks like. Um, with the right treatment and consistent treatment, remission or like relapse or just severity of symptoms like absolutely can go down over time. And a lot of people live very fulfilled lives and they're functioning okay. The thoughts may still come up, but they may not be as distressing. So the goal with treating OCD is to not have so much distress in relation to the obsessive thought. So those thoughts may wax and wane over time. Um, the ability to not engage in the compulsions may also wax and wane over time. Like you said, if there's a traumatic event, that can definitely cause symptoms to worsen again. Just times of stress, big life changes can trigger symptoms. But it does generally tend to wax and wane over time.
It does. And do you, is it typical or is it common to some patients be prescribed medication, or it's mostly therapy and not medication?
Typically a combination is most common. I mean, therapy can be really helpful on its own, and medication can kind of be like a boost to help reduce maybe like the frequency of obsessive thoughts. Typically, I'm not a medication provider, but it's typically like some sort of like an SSRI, pretty commonly prescribed medications. I would say that medication on its own typically isn't as effective as therapy and medication together. But typically both of those together is the most successful treatment.
Yeah, so obviously you have to address the behavior and the thoughts. And so, what role does self compassion play in OCD recovery? So, I know people need that because they're probably just so distressed, or they're just kind of attacking themselves or feeling ashamed. So, how do you teach like self compassion to clients? Like, this is what we can do so you can get that back.
Self-compassion is huge because like we've said many times now is just the shame associated with having these thoughts. I think self-compassion, we can't have that unless we have an understanding of what's going on. So really, I drive really hard psychoeducation. Just I am very persistent and consistent on reminding my clients that like this is OCD. OCD is awful. I mean, just for lack of a better word, like it's a really mean disorder, and that is where these thoughts are coming from. They're not coming from your secret wishes and desires. So there's a lot of psychoeducation just reiterating a lot that like these are not your thoughts, and you have to be kind to yourself and say that to yourself too, but not in a compulsive way, because then we're just reassurance seeking. But I find that just being more gentle with yourself, or like my clients with themselves, um, takes a lot of the distress away. When the thought comes up and then you're able to acknowledge, like, I know what this is. This is OCD. That takes a lot of the power away from the thoughts. That absolutely just, I mean, ERP, I always tell clients that it's really hard. It's a very difficult treatment in therapy. So there's also just general self-care that I highly, highly encourage my clients to engage in outside of ERP, outside of your sessions and your, direct work like that, to really take care of yourself in every way that you can, because OCD is extremely hard and ERP is extremely hard too.
Yeah, because I would think that there's a lot of like self criticism and self judgment. And of course, you spoke about shame. So, yeah, the self compassion is definitely something important to work about. And also, how do you get possibly like family members or a partner? How, do you get them involved to help somebody that's navigating OCD? Maybe they can be part of it, because sometimes family members, they can be so stressful and they could trigger their OCD. So it's like a unit. You have to like work with the people that they engage with most of the time.
Yeah, definitely. Right, it certainly depends on like the type of OCD that's going on and um where in the person's life their symptoms are coming up the most. Um, but if there's I don't think I went into relationship OCD, but that's another subtype. There's a lot of uncomfortable, just feeling very distressed about like the natural uncertainty within relationships. So there's a lot of reassurance seeking in relationship OCD. If that's the subtype that I'm working with a client on, their partner pretty much has to be a part of treatment, because they are part of the compulsion in a way. So they have to, you know, not give the reassurance when their client is or when their partner is asking. So it depends, the level of involvement of loved ones or friends. It depends on the type of OCD. Um, but absolutely, at the very least, education, um, for family and friends, just to know that these things are very much, these thoughts or these distressing things are very much out of this person's control. And like, here's what you can do to help support them in their life. Um, and it's really just like trying to not talk about the OCD too. OCD loves to be talked about. It fuels it better, fuels it more, excuse me. Um, so partners or, if somebody is living at home with parents or siblings, um, highly encouraged to come. Of course, with, permission from the client and whatever they're comfortable with. If they don't want that, then we can try to work around that. But it's usually pretty important for recovery.
Yeah, definitely. Because, you can either have the supportive person or you can have that one that's an enabler, or they kind of know if they create a stressful living space and that kind of
Mhm.
triggers the person's OCD and they're more prone to get into that obsessive or compulsive behavior. So that's
Right.
good to get them involved too. And so, one of my followers, he shared that he has trouble disconnecting from work. So let's talk about like workaholics or the perfectionists. So he said, even on vacation, and he wonders, is this OCD or is it just simply being a workaholic? So, how do you distinguish between an OCD related behaviors and somebody's personality? Because a
Mm.
personality type, you can be the perfectionist type A, you're highly ambitious, but that doesn't mean you're OCD. But even though it looks like you have the kind of symptoms.
Right. Yeah, like the high drive or like the very ambitious person. Yeah.
Mhm.
So there's a few main differences, but with OCD, the obsessiveness will be pretty much the opposite of what they want. So, when I'm thinking of an ambitious person, if they're obsessively checking their emails or like um, thinking about a presentation, like those things usually matter to them and are in line with like their goals, right? There's also just the aspect of um, the compulsive behavior. So with OCD, after a person has the compulsive behavior, the relief is like very short-lived. Like, yes, it relieves the distress from whatever the obsessive thought was, but it's not for a long time. Whereas when I picture a workaholic, once they meet that goal that they're worried about, there's generally like a longer period of time that they feel relaxed or contented or that they achieved something. Um, and again, just kind of going back to, is it impairing with their functioning? There is a disorder called obsessive compulsive personality disorder, um, which I haven't really seen much in my work. I've seen kind of just true OCD, but I remember my professor comparing it to Monica from Friends, who just really likes things a certain way. Um, whereas OCD is in very much opposition of a person's true values, true goals, what they care about, what matters most to them. it will be the opposite that their obsessions are focused on. So those would be the main differences that I notice.
And do you notice, is there like a certain personality type that they tend to be have more have more OCD, or it doesn't matter? It's not like a certain, males have it more than females, or females, or certain personality types, so it varies.
It does vary. I do believe though that it does appear more in women, just statistics wise, but that could also be for a number of, that could just be because women seek treatment more often than men do. So those numbers, aren't 100%. Um, it doesn't, it does not discriminate. People from every background, every race, every gender, um, different personality types. Everybody kind of has that same likelihood, but there are like just temperament styles or people who are more prone to anxiety, and then like the family history too. But when it comes to a certain personality type, I don't think so. That doesn't mean no, but to my knowledge, I don't think so.
Okay, and also, since you said the onset is late childhood and early adolescence, right? Was it late
Yeah,
child?
typically like mid to late adolescence.
And just in your experience, or perhaps there's studies, is there something in their experience during that time that is the onset of OCD, or there isn't?
I
Certain events, I don't know.
Yeah, I'm not, my professional guess would be that most mental illnesses will like have an onset during that time, just given the way that the brain is developing at that age. um the parts of the brain that are like most involved in mental health disorders are kind of rapidly developing. There's a lot going on um chemically in the brain too. Like I think on a physiological level there's a lot of things going on that can kind of make the brain more susceptible to things kind of being triggered, like certain genetic components or genes being triggered during that time. Um, but also, adolescence is a time of risk and not great decision making. So if there are risky behaviors going on, such as substance use, like that can trigger a mental illness as well. So I think it's a combination of just teenagers generally being risky, but also physiologically what's going on at that time.
Okay, and yeah, just the last question, Shannon. If anyone, for people that are watching right now and they suspect they may have OCD, but they haven't been diagnosed, they're just kind of just taking a guess, like, oh, this must be OCD. What are the first steps they can take to get support?
Absolutely. So if somebody thinks that they have OCD, it's really important to get it accurately diagnosed as soon as possible so that they can get the right treatment. The earlier in life and in the progression of OCD, the earlier the better. The better chance that symptoms won't, get as bad as they could, or that it won't last as long. Um, there are a lot of ways to find therapists or providers that specialize in OCD. People can look through their health insurance directories. They can also go on to, it's called NoCD, it's NOCD website. They have like a huge list of providers that are, you can pick your insurance and like your location. You can select filters to find somebody in your area that they specialize in OCD. Um, Psychology Today is a great resource to find therapists if you're looking for like certain specialties as well. You can kind of select that. But those would be kind of the best routes to find a provider.
And I was wondering, in your practice, before you diagnose, do you give certain assessments? How do you know if somebody actually has it? Or I mean, have you told any clients and say, oh no, you don't have it? What kind of assessments do you use?
There is an assessment that I do administer, and I can't remember the exact initials because they are, I think it's DOCCS. And I'm blanking on the creator's name as well, but it it rates severity level of the person's symptoms. So I administer this with the knowing that like OCD already fits this person. But I don't think I have ever had a client come to me thinking that they have OCD and then they don't.
Mhm.
It's kind of been like people are coming for other things and then it turns out that it's OCD. That has been much more common, actually. Like I specialize in ADHD as well. That's like my main, yeah, my main thing. And I've had quite a few people come for an ADHD diagnosis and they leave with an OCD diagnosis.
Oh, how interesting.
Yeah, it
I
it
see.
can look like a lot of other things. Um, just hence emphasizing again just the importance of getting an accurate diagnosis as soon as, and it doesn't hurt to go and like maybe, there's also a fear, I think, that what if this isn't OCD? Like people will have those really scary, distressing thoughts, and they're like, that's another OCD thought is what if this isn't OCD? Because then that would mean I'm a
Oh,
terrible
how
person.
interesting. So
Yeah.
yeah, I was gonna say, did you think they're thinking they have something worse, or oh, that's just the thought process.
Well, I think
Oh,
sometimes it'll come like, you know,
OCD about OCD. Okay.
I know it's like
Okay, that's how it sounded. No.
it's inception there, but it'll be like just further questioning yourself. And that's kind of what OCD like really latches onto is questioning your values as a person and your morals and what you care about. So then if the fear is like, well, if it's not OCD, then this must be the way I really am. This must be my truth that I'm hiding. So sometimes there's a reluctance to seek a diagnosis in case that like it's actually not OCD. But if someone has a feeling that that's what's going on for them, you know yourself best, you know.
And also, can you share with the viewers where they can look you up? I don't know if you have a website or your information. That would be great.
Yes, that would be
Uh,
wonderful. So I do have a website. It's Shannon Wagner, LCSW.com. And that would be like the most central location for everything. I have information about ADHD on there too and resources. I write blogs sometimes. Um, I have an Instagram as well, Shannon Wagner, LCSW. And yeah, I'm so happy that you reached out. This was great. I really appreciate you taking the
yeah,
time and just like kind of putting this out there too, just to help educate on OCD. I think that's really important.
yeah, I really appreciate it. Thank you so much, Shannon. I mean, you you made, I'm sure, a lot of people more knowledgeable about this.
Thank
And
you.
thank you again. And yeah, so I hope people get good information and able to connect with you possibly.
Yes, if any, my DMs are open, my messages are open. I'm always happy just to, give a consult too. If you don't want to work together, we can still just talk about things. So thank you so much, Tanya.
Okay, good. Thank you.